the chat because we will not be able to hear you, although I hope you can hear us. I'm going to very briefly introduce this lectureship, which is one of our Giants in Cardiovascular Medicine series that we initiated this year. We're very excited to honor those who've made Yale Cardiovascular Medicine what it is today, and I think are still playing a critically important role, as Lynda, you'll hear, is doing, in helping guide the next generation and our organization into the future. So just a brief few words before I ask Honorary to come in and introduce our invited lectureship. Dr. Lynda Rosenfeld doesn't really need much of an introduction because she is well known to this organization over many, many years of service, 40 years of service since she joined us in cardiology. But just briefly, Lynda, from what I've been learned from talking to her over the years, had a love of science and really a focus on medicine from an early career stage. She did her undergraduate work at Tufts University before going on to Cornell University in the late 70s for medical school, and then came to Yale as a cardiology fellow, graduating as the first female cardiology fellow, I've been told, in 1982. Since then, she's joined our faculty. The doubling time, I was told when I asked her last night, was quite long at the time for EP, although it's not the case as much anymore. And so she was one of two electrophysiologists for almost a decade here with Dr. Bill Batsford, who we do need to actually also find a way to celebrate as well his legacy. And during that time, Lynda was, not only a phenomenal clinician who built a tremendous practice here in our community, but it really not only mentoring, but educating legions of cardiology fellows. I was able and very fortunate next to Rachel last night at a dinner in her honor, and Rachel spoke really memorably about her experience of coming onto the fellowship and the faculty under Lynda's mentorship, and this community of women electrophysiologists, which I think were able to fit on one table at HRS in the 80s, has now grown, but continues to still need to grow and be mentored into the future. Over the years here at Yale, Lynda played important roles not only as the Goodyear Firm chief, but as a director of our electrophysiology fellowship program. And really, maybe there's not enough time to review all the important impact she's made into our program on individuals and really for women in cardiovascular medicine at Yale. So with that brief introduction, Lynda, thank you for letting us honor you with this lectureship. We're kind of still in the hybrid mode, but we were very excited to be able to bring Dr. Mikos onto campus, and I'm going to have Honorary introduce her and have us really enjoy this lectureship. Thank you.
Eric, thank you so much, and good morning, everyone. It really is a pleasure to introduce Dr. Erin Mikos as inaugural Professor Lynda Rosenfeld Honorary Visiting Professor and Lecturer. This is the second in our Giants of Yale Cardiovascular Medicine series, and we are truly honored to make this tribute to Dr. Rosenfeld, who has been not just a true giant and trailblazer for women in cardiology here at Yale, but really for all of cardiovascular medicine here. Dr. Mikos comes to us from the Johns Hopkins School of Medicine, where she is an associate professor of medicine and director of the Women's Cardiovascular Health Program. She's also the co-editor-in-chief of the American Journal of Preventive Cardiology, associate editor of Circulation. She earned her bachelor's degree and medical degree from Northwestern and completed her training in cardiology at Hopkins, where she stayed on faculty. Dr. Mikos is a really accomplished researcher, very well published, and she's published over 400 peer-reviewed articles, including the 2019 ACC-AHA guidelines on primary prevention. Her research really has been focused on a number of important issues in women's cardiometabolic health, including the influence of sex hormones on cardiovascular disease, and also on the effect of vitamin D on cardiovascular disease. She's also a committed and dedicated mentor and really has worked hard to ensure a consistent pipeline of women in cardiology. I don't think that there could have been a better tribute to the legacy of Dr. Lynda Rosenfeld here. So please join me in welcoming Dr. Mikos.
Thank you so much for that kind introduction. Let me see if I can get, do I need to stop sharing?
No.
Okay. Oh, here it is. Okay, great. Thank you. Such an honor to be here to give this named lectureship in honor of Professor Rosenfeld. So I'm going to be talking today about female-specific factors that enhance women's cardiovascular risk throughout the lifespan. And hope by the end of this, I've convinced you all as the cardiology community the importance of taking a comprehensive reproductive history in your patients. Because if you don't ask your female patients about these factors, you may be missing some really important red flags of risk and miss opportunities to identify women who might benefit from more intensified prevention. These are my disclosures when they're not related to this talk. So first of all, I want to set the stage that sex and gender are not the same thing. They actually are different terms and mean something slightly different. So when we talk about sex differences, these are differences related to biology, related to sex chromosomes, sex hormones, gene expression, anatomy. Where gender is a social cultural term, it's about enacted roles and behaviors, it's about identity. Gender is not binary, it's on a spectrum. And health is determined both by biology and the expression of gender. So both sex and gender contribute to observed differences in women's cardiovascular health. So first, some epidemiology. We've all seen these statistics from the American Heart Association. In the 80s and 90s, cardiovascular disease was going down nicely in men. They were getting statins, their cardiovascular prevention, cardiovascular disease prevention was being implemented. Where women, their cardiovascular risk was ignored. You know, women were getting hormone therapy, they were not getting statins, and cardiovascular disease mortality was on the rise in women till around the year 2000, when this really became to attention. And then this around the time was the implementation of the first women-specific guidelines for prevention and the Go Red for Women campaign. And then there was a dramatic decline in cardiovascular mortality in women and continued decline in men. And this is why I love being a preventive cardiologist, because there's a lot that we can do and make impact. But unfortunately, all of us need to be very alarmed about what's happening on this right-hand side of this curve now. We are no longer making progress in improving cardiovascular mortality. We're no longer even stagnated. We're actually now back on an uptick due to the epidemics of obesity and diabetes and cardiometabolic diseases. And these are absolute numbers, but if you look at death rates, the fastest growing heart disease death rate is actually middle-aged women, which has increased to 7% since 2017. This is an age range that I fall in. It's a busy time often in women's life when they may have dependent children at home, they may have aging parents, they may have a spouse, a partner, a career, where their attention is on everybody else, but women need to prioritize their own heart health. So this is one of our studies when we looked at death rates in women under the age of 65 in the United States using data from the CDC Wonder. And in younger women, cancer is the leading cause of death. And we showed over this 20-year period that cancer mortality has continued to decline in younger women, which is good. But unfortunately, since 2010, heart disease mortality is not declining. It's actually on an uptick at 0.5% per year. And so this gap is narrowing. And if these trends are not overturned, heart disease is set to overtake cancer as the leading cause of death in younger women too. And unfortunately, I was really disheartened when this study came out last year that we're losing ground in awareness that heart disease is the leading cause of death of women. The American Heart Association has sent out surveys over the years, and in 2009, 65% of women knew that heart disease was the leading cause of death, and this declined only 44% in 2019. So we're losing awareness. More women still cite cancer as the leading cause of death. And this lack of awareness was particularly noted among Hispanic and Black women, and also among younger women who arguably we can make the most impact on primordial prevention if we start at a younger age. So we think, we're getting the word out there, but we're not. And this is why we really need to partner with community partnerships and really need to shake things up with novel ways of implementing prevention and engaging community leaders. So we all know the traditional risk factors for cardiovascular disease, but even among them, there's disparities by sex, where, for example, diabetes and smoking confer a greater relative risk in women than in men. So these are various CAD outcomes. If we look here, MI, diabetes confers a 4-fold increased risk in women and a 2-fold increased risk in men. And similarly, smoking, bad for everybody, but it confers a greater relative risk in women. Now, what about blood pressure? So blood pressure generally is on a linear rise throughout the lifespan, but even then there's differences in trajectories by sex in this one study, that women are on a different trajectory of their blood pressure their whole lifespan. On average, women start out with lower blood pressure than men, and then by midlife, though, they overtake men, so that on average, older women have higher blood pressures than men. So if you look at change from baseline, women are on a steeper trajectory their whole lifespan than men for blood pressure, which sets the stage for not only cardiovascular disease presenting later in life in women, but also presenting differently. Now, while we think there's generally a linear rise in blood pressure, data from the SWAN study, as we wrote about in this editorial with Dr. Lau at MGH, is that women do have different patterns due to the menopause transition. Where some women, continue to have a linear rise in blood pressure, where some women at the menopause transition actually plateau, and other women have an accelerated rise. Now, additionally, there are unique risk factors that women experience throughout their lifespan that men do not, related to pregnancy and hormones and menopause. And this is why it's so important to take a comprehensive reproductive history and ask your patients about all of these things to identify potential red flags of risk and opportunities for more prevention, their screening or implementation. So starting with younger women, considering things like age of menarche, history of polycystic ovary syndrome, oral contraceptive use when combined with smoking, infertility, particularly the use of assisted reproductive technologies, may have some cardiovascular risk, spontaneous pregnancy loss, and premature ovarian insufficiency. So I'll touch on some of these. So for menarche, if you look at a cohort of now middle-aged women in the UK, it asked them when they had the onset of their menarche, their onset of their menses. Women who had an earlier onset at age 8 to 11 were much more likely to be in poorer cardiometabolic health later in life. They had higher waist circumference and BMI and more hypertension. And if you look at events, even in adjusted analysis, there's a U-shaped curve with menarche and coronary disease risk, where both early menarche before the age of 10 and late menarche after the age of 17 is associated with CHD risk. So the early menarche may be that girls have to have a certain amount of adiposity for the onset of menses, and it may be that they're with poor cardiovascular health and increased weight gain in younger girls. That this not only might trigger earlier menarche, but also set the stage for adipokine dysregulation that tracks into later life. And the older onset of menarche may indicate a hormonal imbalance and estrogen deficiency state. And again, I argue, I'm not sure, I won't have you raise your hands, but how many cardiologists actually ask their female patients, about these factors, like when their onset of menarche is, and maybe, missing potential risk. One of the things I've been really interested in is the risk associated with polycystic ovary syndrome. This is the most common endocrine abnormality of women in reproductive age. And there are different phenotypes, so there is some heterogeneity. So not all PCOS is associated with increased risk, but it does seem to be the hyperandrogen phenotype, the classical PCOS is associated with cardiovascular risk. There is a number of cardiometabolic risk factors. Underlying PCOS is insulin resistance is the big driver. Most, but not all these women have increased BMI. There's a dyslipidemia pattern with the elevated triglycerides, LDL, low HDL, elevated blood pressure. And then the hyperandrogenism. If you look at Mendelian randomization studies, there's some debate whether PCOS is directly causal to CVD or whether it's all mediated by the androgens and these and body mass index. But it is associated with risk, even if it is through those mediators. This was a meta-analysis that we performed recently. It was published looking at coronary artery calcium across different cohorts, and women with PCOS compared to BMI matched controls were much more likely to have subclinical atherosclerosis, about a twofold increased risk of both prevalent and incident coronary calcification compared to their controls. And these women were still fairly young, in their 40s. Now, in terms of future CVD risk, there is some difference across studies. It does depend whether how PCOS was defined, how CVD was defined, but overall, there seemed to be a 30% increased risk of an incident cardiovascular event. But there's some question about whether this tracks into later life after the menopause transition. Clearly, there's excess risk during the reproductive years, but whether this still carries forward. This is a Danish registry looking at women with PCOS and incident CVD, and even an adjusted analysis of women of reproductive age. There was this excess hazard of CVD. Although after menopause, it didn't seem that a prior history of PCOS didn't seem to carry risk later in life to women who had already survived to menopause free of CVD. It's likely because with the loss of estradiol and the relative hyperandrogen state of being postmenopausal may overshadow any previous risk conferred from their PCOS during the reproductive years. This is one of our studies that was just out in Jaha last week, where we actually looked at PCOS and cardiovascular complications at delivery. So we're talking about the long-term risk, but even at in delivery complications, we used a national inpatient sample over 17 years. And we showed even with some of the limitations of ICD coding that both PCOS and obesity has been rising among pregnant women. But in adjusted analysis, having a history of PCOS is associated with 56% increased risk of preeclampsia and a twofold increased risk of heart failure, peripartum cardiomyopathy, VTE at pregnancy delivery. And I think a lot of people may not be aware of this. There's increased risk of infertility with PCOS, but even once they become pregnant, because of the likely underlying cardiometabolic abnormalities that these women have, they're more likely to have cardiovascular complications and may need more intensive follow-up during their pregnancy and delivery. Now, one of the hallmarks of PCOS is irregular menses, menstrual irregularity. And the Nurses' Health Study said, even if you just asked about menses, this is also independently associated with cardiovascular risk. So these were younger women in the study, ages 20 to 35, followed for 14 years. But these female nurses, these women who reported having very irregular menses here in the red bars, were 53% more likely to have an incident coronary event. And this is adjusted for all these risk factors. So again, I think that many cardiologists don't ask their female patients, about their menstrual history, but again, may be a missed opportunity to identify women who may be at actually increased cardiovascular risk. Spontaneous pregnancy loss is also associated with cardiovascular risk. And this is also data from the Nurses' Health Study that women with a pregnancy loss in the red bars compared to no pregnancy loss in the blue bars had increased risk of CVD, coronary disease, and stroke, about a 20% increased risk. Now, there's risks related to pregnancy, both number of live births, but also these APOs, these adverse pregnancy outcomes. And I don't have time to go through all of them today. I'm just going to touch on some highlights. But in multiparity, this is one of our studies from the MESA study. These women are now middle-aged to older age, but we showed that women who were grand multiparous, more than 5 live births, were much more likely to be in poor cardiovascular health compared to women who were less parous. And in adjusted analyses, there seems to be a J-shaped relationship with both nulliparity and grand multiparity associated with increased CVD risk, even after you adjust for risk factors. Now, I will mention that some studies have actually suggested that parity is a risk factor for CVD in men too. So this does suggest that there is some confounding by social economic status and cultural factors, but the risk is greater in women, suggesting underlying biological effects. So what are the mechanisms of this? Women tend to gain weight with each pregnancy. And some of the studies, I'm not able to have time to show today, but we showed in MESA that women who had more parity had more adipokine dysregulation with higher leptin levels and resistin levels and lower adiponectin levels. They also had higher androgen levels that may be underpinning their cardiovascular risk. Now, breastfeeding may be protective. Of course, this is all observational data. So there's clearly issues related to confounding by women who are able to breastfeed. But in this meta-analysis that was recently published, over 1 million women who were parous, who on average had over 2 live births, 82% did have report ever having breastfed at any time in their life. But what we saw is women who had breastfed, and these circles represent the different cohorts in this meta-analysis. There's about 11% reduction in incident CVD over an average 10-year subsequent follow-up, particularly a significant reduction in fatal CVD and also reduction of stroke. Now, breastfeeding beyond 12 months was a little bit less clear, but the benefit was clearly for breastfeeding, at least for the first 12 months. Now, gestational diabetes is pretty common, 1 in 10 pregnancies, and there is a huge increased risk for progression to type 2 diabetes, a 10-fold increased risk of developing type 2 diabetes. And this is why glucose monitoring, glycemic status is so important after delivery, and why there's been a lot of efforts looking about transitional clinics and getting women with GDM helping with weight maintenance and physical activity, and looking at things like metformin and GLP-1 receptor agonists and other things for prevention. But GDM is also associated with CVD risk, and this is another meta-analysis showing about a 2-fold increased risk of CVD. Now, some of this is because so many of these women with GDM develop type 2 diabetes, and we know type 2 diabetes is associated with CVD. But there are data suggesting that even among women who don't develop interim type 2 diabetes, they're still at elevated risk. In this meta-analysis, is 56% risk. And I don't have the slide for this in this particular talk, but the Cardia study also showed that women who had GDM, even if they didn't develop incident type 2 diabetes, had a 2-fold increased prevalence of coronary calcium. And this is one of our studies that we collaborated with McGee in Pittsburgh. They had an interesting cohort of women who had adverse pregnancy outcome, and they brought them back 10 years later for cardiovascular testing. They published the preeclampsia data, and they let us work with their GDM data. And then when these women came back for their subsequent echo and testing, the average age was 36. So they're still young. These are young women. But women with GDM compared to BMI match controls, so we definitely matched by BMI. But women with history of GDM, when they came back 10 years later at age 36, they still had increased wall thickness, more abnormal diastolic parameters. They had decreased brachial reactivity, and they had decreased microvascular function by this glycotalix test. So even at this young age, they already had evidence of a subclinical cardiovascular dysfunction. So again, so important for prevention. And if we, don't be thinking about asking these women about their cardiovascular risk and implementing prevention, there can be missed opportunities. But one of the biggest red flags of risk is having a history of preeclampsia. Affects 5 to 8% of pregnancies, and there's significant racial ethnic disparities, likely driven by both the higher prevalence of chronic risk factors like chronic hypertension and obesity, which have a greater prevalence among Black women, but also the issues with structural racism and social determinants of health that lead to these poor outcomes. So Black women are at much greater risk for preeclampsia. And there are significant disparities with interaction with social economic status. So this is one of our studies we presented at ACC. It's under review right now, where we showed that individuals who had higher income compared to lower income, did have less likely to have complications at delivery, but that there was significant interactions with race, ethnicity, that even high income Black women with preeclampsia had worse outcomes compared to low income white women, or high income Black women were still more likely to have peripartum cardiomyopathy, coronary syndrome, stroke, heart failure, all these adverse cardiovascular outcomes at delivery. So in other words, having a higher socioeconomic status, even that was still not protective or offered any protection for Black women who still experience terrible disproportional adverse outcomes with pregnancy and with the rising maternal mortality in the United States. I mean, this absolutely has to be addressed. This is a crisis. We need to improve Black maternal health. So, we've shown, of course, that preeclampsia is associated with cardiovascular outcomes at delivery. And because Black women here in the red have higher prevalence of preeclampsia, they're more likely to have peripartum cardiomyopathy and heart failure. But even if we can get women through the delivery and the postpartum period where there's so much mortality, having a history of preeclampsia is associated with long-term risk, even more than a decade after their index pregnancy. And this is why we as cardiologists, who may not even maybe see them at the time of delivery, but need to be aware of this for later, is that they have a 4-fold increased risk of heart failure and a 2-fold increased risk of cardiovascular disease. And 2 out of 3 women with a history of preeclampsia will ultimately die of cardiovascular disease. And so this is our wheelhouse for prevention. And I really like this nice figure of meta-analyses that Dr. Davis and Dr. Bello put together in a recent JACC publication, where you have the adverse pregnancy outcomes and the various cardiovascular outcomes. And you can see that all these various things are associated with about a 2-fold increased risk of having an adverse cardiovascular disease later in life. So what's the chicken versus the egg? Well, it may be that women, we're not all that healthy now entering pregnancy. So we know that cardiovascular health in the US population is getting worse over time, and more morbidity shoved, in younger and younger individuals. And so that there was maybe more increased prevalence of obesity and chronic hypertension and dyslipidemia or glucose intolerance that was not really recognized going into pregnancy. And then at pregnancy, being nature's free stress tests, these became clinically manifest in these APOs. But it's also thought that these adverse pregnancy outcomes contribute to future CVD risk also in a causal fashion, that the thrombotic and inflammatory milieu of preeclampsia, that the increased sensitivity to angiotensin II and sort of the hormonal milieu that's released because of the placental ischemia can further propagate endothelial damage and set these women up for later life maternal cardiovascular risk. And a lot of interest has been that I've been working on is, working on these postpartum transitional clinics and making sure that women who have had a preeclamptic pregnancy have the appropriate handoff and follow-up to prevent these long-term complications. But we really need to be thinking about upstream contributors of social determinants of health before pregnancy and between pregnancies, because one of the biggest risks for having an adverse pregnancy outcome is starting pregnancy, with poor cardiovascular health. So this really needs to start upstream and optimizing the cardiovascular health of girls and female adolescents prior to pregnancy. And we know that this is generational. So a woman's cardiovascular health during gestation is associated with her offspring's cardiovascular health. In this study, they brought 10-year-olds, offsprings now 10 years later, and the children, had poor cardiovascular health by the HA Life Simple 7 criteria. If their mother had poor cardiovascular health during gestation. So this is all related, and this is why we need to support young women before, during, and after pregnancy to only not just to optimize her own health, but her offspring's cardiovascular health too. And then there's risks related to menopause, both going through menopause early and sex hormone levels after menopause, and the interaction of menopausal hormone therapy. So menopause is not a disease. This is a life transition that all women who live long enough will go through. But there is a number of metabolic changes that happen at the time of the menopause transition. So there's an increase in visceral fat deposition in the abdomen. There's an increased more dyslipidemia pattern with increased triglycerides, increased LDL, decreased HDL with the loss of estradiol. There is more of an increased insulin resistance state post-menopause than premenopause, with more endothelial dysfunction, increased blood pressure, and an increased sympathetic tone. So menopause is a good time to optimize women's cardiovascular health. And we've established a menopause clinic at Hopkins, and I work with our GYN colleagues and see their referrals. So people may not be aware, but even vasomotor symptoms are associated with cardiovascular risk when they're very frequent and when they're persistent. And again, I think very few cardiologists ask women about their hot flashes. But in the SWAN study of women aged 42 to 52 who was undergoing the menopausal transition, women with frequent vasomotor symptoms more than 6 days out of a 2-week period had a 51% increased cardiovascular risk. This is over a 22-year subsequent follow-up. And women who had persistent vasomotor symptoms, where they didn't go away after 3 years, but they persisted, had almost an 80% increased cardiovascular risk. Now, when women go through menopause early menopause there's a linear relationship approximately with early onset menopause with increased cardiovascular risk, even in adjusted analysis, particularly before age of 45 and especially before the age of 40. The average age of menopause in the US is 51. And so women go through this acute change in their hormones with this abrupt decline in estradiol, a life change that men don't go through. Men do decline in testosterone about 2% per year, but this is gradual over decades, this andropause, where women have these acute hormonal changes that impact all these cardiovascular risk factors, as I mentioned. Now, the postmenopausal ovary is still metabolically active. It doesn't not making estradiol anymore, but it can still make androgens. It still can make testosterone for even a decade out. And a lot of my work, and it's focused in MESA, has been looking at sex hormone levels in women after menopause. And we showed in the MESA study that women with higher testosterone levels compared to estradiol, so post-menopause, if they're not on hormone therapy, circulating estradiol is from peripheral conversion of testosterone. But women with higher androgen levels, a more male-like phenotype, had increased risk of cardiovascular disease. And this is even after we adjusted for risk factors like blood pressure and glucose intolerance. And I didn't have time to go through all of this, but a number of my studies, we've shown that women with higher androgens after menopause had just a worse adverse cardiovascular phenotype. They have, increased cardiac remodeling, LVH, aortic stiffness, reduced brachial activity. They had more plaque progression, higher BNP levels. I showed you the event data and cognitive decline. But whenever we submitted these papers, we always get the same question from reviewers, what do we do about this? Because we're not giving, hormones back based on the landmark study like the Women's Health Initiative for the sole purposes of CVD prevention. WHI, as you all know, had shown that given oral estrogens, which was a conjugated equine estrogen, the primary circulating estrogen in premenopausal women is 17-beta estradiol. So what was given in these trials is different actually than circulating estrogens. But this oral estrogen progestin, the women not only did not have benefit, there was excess cardiovascular risk with a number of important caveats. One being that the mean age was 63. So the vast majority of these women were significantly past the menopause transition. So there's a lot of talk about timing. Most of the excess risk was in the older women. So that's why I definitely wean women off at older age. There didn't seem to be excess risk at all for women that were closer to the menopausal transition, but there wasn't a clear benefit. So we're still not using it for the sole purposes of prevention. This contrasts other studies like this older study from Denmark, which was a trial, but it was open label, and it was back in the 90s when we weren't giving statins, but oral hormone therapy actually was associated with decreased cardiovascular risk in women, particularly women under the age of 50. So whereas our current standpoint, the pendulum doesn't have to swing so far that we don't give hormone therapy to anybody, but it is part of shared decision-making based on a woman's age, how far she's out from menopause, how symptomatic she is with her menopausal symptoms, and her underlying cardiovascular risk. So we're not using it for the purposes of CVD prevention. We now have statins and other things that are better for prevention. But there is still a role for women under 60 or who's within 10 years of menopause who have symptomatic menopausal hot flashes or night sweats that are really quite bothersome despite lifestyle changes or non-hormonal therapy. For a woman who goes through menopause early without contraindication using menopausal hormone therapy, at least until the average age of natural menopause. So if a woman has premature ovarian insufficiency, sometimes we even use oral contraceptives because they have higher estrogen level doses compared to the typical estrogen in the menopausal hormone preparations. But generally, we don't recommend menopausal hormone therapy if a woman is more than 10 years out from menopause or over the age of 65. So I do work with my women patients for a plan to wean slowly if they're still on this. And we want to avoid oral estrogens, being the key oral estrogens, and women with a history of cardiovascular disease, blood clots, high triglycerides, gallbladder disease, or prior breast or endometrial cancer. Now, vaginal estrogens, topical estrogens are fine and because they don't have that much systemic absorption. And many women, their main symptoms is genital urinary symptoms. And so the topicals are fine. And there's some data suggesting that there may be less risk with the transdermal preparation if you're doing systemic hormone therapy. So sometimes that might be consideration for women that have slightly higher cardiovascular risk. But the importance is doing a cardiovascular risk assessment prior to menopausal hormone therapy. And this is why we've established our menopause clinic in conjunction with our GYN colleagues. So this is was a figure from a recent paper that I worked on with some MGH collaborators. But essentially, it's part of shared decision-making. And those are the contraindications were not recommended if they have the contraindication or they're older at high cardiovascular risk. But a low-risk woman doesn't have to avoid it. It can be considered if she's very symptomatic. And then if someone only has, one or two risk factors, what I do in my practice is I get a coronary calcium score to see if they have disease or not. And I'll talk about coronary calcium scores here in a minute. But as you heard, I was part of the 2019 ACC-AHA primary prevention guidelines, and I was really pleased that they finally now have called attention to these female-specific factors as risk enhancers, particularly premature menopause or these adverse pregnancy outcomes like preeclampsia, as well as inflammatory conditions like rheumatoid arthritis and lupus that are more prevalent in women. So in the setting of these, in individuals who are otherwise borderline or intermediate risk, this would raise them into a higher risk category where statins would be recommended to be considered. And this is the figure from our guidelines. So we did say to still start with a 10-year risk assessment using the pooled cohort equations for ages 40 to 79. And we acknowledge that this is not perfect, and it can both under and overestimate risk. And this is just why it's the start of the conversation, not the end of the conversation. But low risk individuals, less than 5% 10-year risk, often lifestyle modifications enough. Where high risk individuals above 20% 10-year risk, you want to do lifestyle plus high intensity statins to lower the LDL by 50%. And then there's this big group in the middle where a lot of women fall. And this is where you have the clinician-patient risk discussion, and you consider those risk-enhancing factors, such as that reproductive history I just reviewed. But if there's still uncertainty about the net benefit of statins or patient indecision, or I get a lot of referrals for patients that are somewhat reluctant about statins, this is where we gave in our guidelines a 2A indication to consider coronary artery calcium score to help refine risk a little better and guide shared decision-making. So I think you're familiar with the coronary calcium score. It's done by non-contrast CT. It's very low radiation, 1 millisieverts. And as plaque is building up in the arteries, a certain percentage of it can become calcified. So it's a good marker of the presence of underlying atherosclerosis. And it's really, when compared head to head and across all these epidemiology cohort studies, it actually is a better predictor of risk than age, than LDL, than pooled risk, the pooled cohort equations, better than IMT, better than ABI, better than the CRP. Head to head, it had better change in the C statistic from all of those. And so that's why I got the sort of higher billing in the prevention guidelines. Because it's actually it's not just predicting risk, it's actually measuring disease itself. It's a marker that there's disease there. It's a disease marker. And it really is integrating a lifetime of risk exposure from both these traditional and non-traditional risk factors and genetics. And so the presence of absence one can upgrade or downgrade risk. So, what it does predict risk in women, and it actually predicts risk in women a little better than in men. But this is data from MESA that I was involved in. This dotted line is the 7.5% threshold, where we generally think is the net benefit threshold for statin therapy. And we followed participants for over 10 years. So those with a 0 calcium score had a very low event rate up the next 10 years. Now note that this is not a 0 event rate. A 0 score is not 0 risk, and it doesn't surpass good clinical judgment, and it's not meant to be applied to people who are giving you a good story for ischemic heart disease. This is for asymptomatic individuals. But it's while it's not a 0 risk, it's a low enough risk that patients and their clinicians may feel comfortable in deferring statin therapy. On the other hand, any non-0 score crosses over this threshold by 10 years in a graded fashion. With the higher the score, the higher the risk. So we recommend statins for calcium scores above 100 or above the 75th percentile, but we said it should be considered really for any non-0 score. Now, while women at a given age are less likely to have prevalent coronary calcium, the presence of coronary calcium actually is a greater prognostic risk in women than in men. So this is data from the Coronary Calcium Consortium led by my colleague, Mike Blaha, looking over 20 years. Both men and women with a 0 calcium score had a very low event rate for CVD mortality over 20 years. So this is the scale, this is 1% here, so very low event rate. On the other hand, having coronary calcium is associated with risk in both women and men, but a 26% greater risk in women. So if you look at an absolute score, like if you have a score of 100 or a score of 400 or 2 vessels involved or 3 vessels involved, in that setting, it confers a greater risk in women than in men. And this kind of shows the same thing. This is looking at patients with diabetes, but again, for a given score, it actually confers a greater death rate in women than in men. And even in adjusted analyses, while the score goes up, predicts risk in both men and women, the hazard is greater in women for a given score. So it's a stronger prognostic marker in women. Now that's generally applied to asymptomatic individuals, but if you look across countries, actually angina is actually more prevalent in women. But in the setting of angina, women are far more likely to have non-obstructive disease across the age range. And we know now that ischemia with non-obstructive coronary artery, that the angina is not just from coronary stenosis, that there's many mechanisms from myocardial ischemia. And it's important particularly not to miss these major endotypes for ischemia with non-obstructive coronary artery, the coronary microvascular dysfunction and vasospasm. If you have a patient who's telling you a good story that this could be likely angina or ischemic heart disease, and you send them to cath or do your CTA and there's no obstructive disease, you're not done. You owe these women a diagnosis. One, because we want to prevent events, because this is not benign, as I'll show you, but also for quality of life and for symptoms. And so too much people get dismissed at this stage, or they're told that their symptoms are not cardiac just because they don't have obstructive disease. So we know now about the importance of the microvasculature, and once you rule out obstructive disease, the 2 major endotypes, having CMD, which is hallmarked by a reduced coronary flow reserve, less than 2, that in the setting of a stress, including a provocative stress like a vasodilator, that there's an inability to dilate the coronary arteries and respond to stress. So once you rule out obstructive disease, a low CFR is a marker of microvascular dysfunction. And you can do this on invasive testing in the lab, or you can do this non-invasively with a stress PET or stress MRI, as long as they're getting a myocardial blood flow reserve. Or it can be done by stress echo with Doppler of the coronary artery, but that's really technically challenging. Very few labs actually do that. Now, the other major endotype is vasospastic angina of the epicardial coronary arteries as well. But these are associated with events. We've seen data from the WISE study that in women with symptoms of angina, symptoms of ischemic heart disease without obstruction, even if they have mild disease or even no disease, they had a greater 5-year event rate compared to completely asymptomatic women controls who don't have angina. Now, some might think that if you don't have obstructive disease, that non-obstructive disease may be less symptomatic or more benign if you have angina without obstruction. But I like this comparison that Dr. Reynolds did, comparing patients that were screened for enrollment of the ischemia trial. So to get in the ischemia trial, everybody had to have evidence of moderate severe ischemia on a non-invasive test. And then they had a CTA where left main was ruled out. But if they had obstructive disease, they got enrolled in the ischemia trial. But if they had ischemia and non-obstructive disease on their CTA, they got enrolled in this CHOW registry. And like we see from other cohorts, that the trial participants with obstructive disease were predominantly men, and the registry patients, which was non-obstructive disease, were probably female. But otherwise, they actually look pretty symptom. If you look at like the number of ischemic segments on their index stress test, or how frequent their angina was, or how severe their angina was, if you look at frequency and look at quality of life, I mean, you would probably be hard to pick which bar is the trial participants and which one's the registry. Meaning that, you know, they still have similarly poor quality of life, they similarly have poor angina, and just because they don't have obstructive disease, you can't ignore them. You know, we need to identify it. One, we need to get them on risk-reducing agents like statins and ARBs and aspirins, but we also can do things to improve their symptoms and quality of life with anti-anginals, calcium channel blockers, ranolazine, and so forth. So to kind of summarize this black part, you know, men tend to have greater calcification and fibrous cap, and women tend to have smaller vessels. They may have more plaque relative to their size of their arteries, less calcification, and more ischemia of non-obstructive disease. And just quickly to kind of end with a couple of things, I really am interested in patients' experience in the healthcare system. And one of the things we looked at is patient-reported outcomes, looking at a national survey of individuals who had ASCVD. So this is secondary prevention patients who are the highest risk. And we found that even after we adjusted for all these risk factors, including SCS factors and comorbidities and other cardiovascular risk factors, that women were 25% more likely to report that they had poor communication with their healthcare provider. And they were 23% more likely to report that their doctor never, only sometimes listened to them. And they were 20% more likely to say that their doctor didn't show them respect or spend enough time with them, and they had poor satisfaction with their healthcare system. Now, when we submitted this paper, we had a reviewer say, you know, well, these are subjective data. These are patient-reported outcomes. Maybe women just whine more. Maybe women just expect more out of their healthcare visits. So we're like, okay, so we went back to look at objective data. And these are all patients with ASCVD. So they had a class 1 indication for aspirin and statins. And we showed that women were underprescribed statins by pharmacy data and underprescribed aspirins relative to men, and they had more ED visits. In other words, women were being suboptimally treated, and they felt that way too. So for the sake of time, I'll skip this, but I've done a lot about underreporting of women in clinical trials and showed in lipid-lowering trials and cardiometabolic trials that women are underrepresented relative even to the disease burden in the population. And emphasize the importance of actually having diversity in trial authors, that if study has more women authors or first or last author of being a woman, they're more likely to report sex and gender analyses. But there's a disparity in the proportion of women who are in cardiovascular clinical trial leadership. But there has been some studies, such as this heart failure study, suggesting that as trial authors increase, that there maybe more women participants enrolled. The correlation is not perfect, it's only 0.39, but suggesting if we get more women in cardiology and trial leadership, that may benefit women patients. And this is one of our studies looking at AFib studies. And again, we showed very few women authors of these trials, but that there was a correlation between the number of women authors and the number of women enrolled in the trials. And so I'll skip these. But we've also published about disparities in grant funding. This, unfortunately, we couldn't look at submitted grants by NIH reporter, but only funding grant, but showed that 80% of NIH grants still go to men, and men get more dollars. So to end with, because I want to have some time for questions, is cardiovascular disease is the major cause of death of women worldwide. That women and men share many risk factors, but several are unique to women, and it's really important to assess the reproductive history for early prevention and treatment of CVD. The atherosclerotic plaque is prevalent and it's prognostic in women, so all plaque matters. Don't ignore plaque, especially if you're getting CTs for other indication, and they comment qualitatively on the presence of coronary artery calcium to note that coronary microvascular dysfunction can be present even if there's no obstructive disease, that women are underrepresented in clinical trials and results are often not reported by sex. And to listen to women when they're telling you something is wrong, listen to women's symptoms. And there's a lot of opportunities remain to improve representation of women in cardiology and cardiovascular trial leadership. I'm sorry, I had to skip through that part of it, but we're running out of time, but that this likely will benefit our women's patients when the workforce is more representative of the patients that we take care of every day. And a last plug, I am an editor-in-chief for the American Journal of Preventive Cardiology, so I encourage you to read our journal, submit to our journal, and any fellows that are online or here, you can join our society, ASPC, for free when you're a trainee. So please consider joining us. And just a big shout out to my mentees who are the joy of my career. And you might recognize Andy here, who I'm so proud of, and I hope he's doing well here at Yale, but all the individuals who have touched my lives, and it's been my honor to work with them on this work. So thank you. Read the chat if I can hear the sound.
So maybe we should take some early questions in the room and then we can see if they're in the chat.
Yeah.
Kind of close the chat right away.
Yeah, no, I'm looking at it.
Oh, yeah. Yeah.
We'll take some questions.
So, thank you.
Yeah.
Maybe if I
Yeah.
no, I was gonna say anyone else. I had a question around you provided some compelling data on the importance of asking questions and starting prevention early. In women, their lifetime risks, accumulate. So I kind of wanted to get a sense from you based on the evidence. Do you have an approach that you use in actually guiding women early in life around what is the ideal, from the perspective of cardiovascular disease risk, ideal time for reproduction? And follow-up is, do you have any data that suggests that different birth control strategies have different risks on later cardiovascular disease risk?
Yeah, a good question. So first of all, women of reproductive age, we got to do risk factor screening and make sure we don't miss things like FH. So FH is autosomal dominant, so women are equally benefited, equally affected as men. But there is no longer with FH, women don't have the sex advantage of the 10-year delay compared to men. That in the setting of FH, onset of ASCVD is the same age in men and women. And too often I see women who are not treated, they have very high genetically elevated cholesterol and they're ignored because they may possibly get pregnant. But women have decades of reproductive years. And if you don't treat women who with very high LDL for decades and they're marinating in all this LDL, and then they suddenly they're early middle age and they already have ASCVD. So make sure we treat women. You can work around timing of pregnancy with withholding statin therapy, although statins may not be as teratogenic as we think, but it's better to have short interrupted times of treatment than not. The biggest thing I think we need is a public health. So again, all these adverse pregnancy outcomes are associated with cardiovascular risk, but things like chronic hypertension, obesity are driving them. This is why APOs are on the rise. And so we need population strategies for improved cardiovascular health. In general, most women are at lower cardiovascular risk, that oral contraceptives are generally safe and safer than actually the risk of pregnancy. If someone is particularly high risk, they've established CVD, it's better for, to use something long acting like an IUD, a LARC. Those can be used even in women who have CVD, so they're safe. So either the progesterone base or we recommend IUDs for those. We try to have less of the estrogen, so using the lower estrogen formulations as possible, or completely non-estrogen, a progestin base if woman is very high cardiovascular risk. But the important thing is just not losing them after this pregnancy, the transitions, the handoff in care. After delivery, often women naturally are so focused on the baby and often not their own cardiovascular health. And, I have always argued to have the woman's blood pressure checked when they go take the infant to the pediatrician, and finding ways, novel ways, using technology, using home visits, telemedicine, how we not lose these women. In terms of once they get to be, more age of 40, again, I take this history. And so if you don't want to ask all these questions, I have it in a new patient intake form. So women fill this out ahead of time, so, that you can, just capture this information by having them self-fill this out. But I use a lot of coronary calcium scores in my practice. So women do still have maybe lower risk at a given age compared to men, but in the setting of subclinical atherosclerosis. So if I see any of these risk enhancers, I kind of follow the guidelines. If it's not a slam dunk clear decision whether they should be on statins already, then I'll get a calcium score. And then if it's 0, and we don't start statin, I may repeat it in 5 years. For younger women under the age of 40, like PCOS, sometimes the calcium scores, they just don't have time to calcify their plaque yet. So I'll look at like carotid plaque, not INT, but carotid plaque in those individuals as well. Yes.
Thanks for that wonderful lecture, in particular honoring Lynda.
Yeah.
Wonderful. I really do think you're onto something when you're, as you discussed, the testosterone to estrogen ratios, both in premenopausal women and the reason perhaps why the incidence rises in postmenopausal women. There's an interesting subset of androgen excess PCOS individuals who are thin, they have a normal BMI, and they're insulin sensitive. We've done some studies with a collaborator. They have endothelial dysfunction. So I'm wondering if you have any thoughts about how androgens may be interfering with beneficial effects.
Yeah, no, absolutely. I actually think that we always talk about the female advantage because of estrogen being protective, but I actually think it's the opposite. I think testosterone may be toxic, and that's like men of earlier onset. Because actually, there's studies, I take care of transgender patients too, and gender affirming therapy is so important. But there has been studies that show that if you give transgender men testosterone, so these are female sex at birth, male gender identity treated with testosterone, that they have endothelial dysfunction, brachial reactivity. We do see sometimes increase though insulin resistance and glucose intolerance with those or elevated blood pressure. But the question is what to do about it. People ask me in my research, should we be measuring sex hormones in all these individuals? I mean, we're not measuring it clinically after menopause, but I do the usual things like statins and things that work. But yes, I think this is maybe the link that ties in PCOS and menopause and the excess risks we see both with testosterone therapy. There's a lot of questions about men with hypogonadism, whether testosterone therapy is safe or not. There's an FDA warning. Some, but not of all studies have shown that testosterone therapy was associated with excess cardiovascular risk, but not all studies have shown this. Clearly, low testosterone levels is a marker of CVD risk, but then with low testosterone tend to have poor health, more diabetes and obesity. And it doesn't, it may not be that treating men with low testosterone may not prevent those events. The T trials, CT angiograph trials, was published in JAMA a few years ago by Matt Budoff, and showed actually increased plaque, non-calcified plaque progression with testosterone therapy. So in men, there's a big clinical trial ongoing, Travers trial. It's a 5-year outcome trial, enrolling men with hypogonadism to show if testosterone therapy is associated with cardiovascular benefit or harm in those. And then right now, though, I except in the transgender population, I avoid women, tell women not to use testosterone. Many of them want to use it for libido and other issues, but I'm concerned about giving testosterone to women unless it's part of a gender affirming hormone therapy because of these concerns.
Thank you. It was an amazing talk and a tribute to Lynda Rosenfeld's legacy here. So it's really terrific. Thinking about these milestones, you really covered the lifespan of a woman, and it seems like there's not any structures in place to really identify these moments and then make lasting changes. We're seeing women postpartum who have had hypertensive disorders of pregnancy, and exactly what you said, having them see a cardiologist, doing a full risk assessment, but take on more information, and the whole attention is diverted, obviously, to the baby. Are you aware of any, like, or do you practice or implement any structural kinds of plans for women who have had an adverse event during pregnancy? It's such an opportune time, other than within that immediate postpartum state, and what are your thoughts on?
Yeah, I mean, the postpartum state, we have a postpartum hypertension clinic. The no-show rate's pretty high with that. There's a lot that we're doing with research-wise. So we have, one of my colleagues has a grant where they have do behavioral health coaching. And so they have coaches call. And so, you can do self-monitoring of blood pressure. And this is based on weight management. So another model we're doing with, home visits, but this is all sort of a part of the, it's part of grant funding, because otherwise how you cover all this clinically. But we've been trying to find out, like, we're piloting use of apps and things like that to track blood pressure, where women can self-monitor and send their readings in, and then we can make adjustments, but at least they're trying to monitor them and follow up with coaching, because it's just so hard to get them back in clinic. We schedule all of them to come to our postpartum preeclampsia clinic, and the no-show rate, this is Baltimore, and there's a lot of, social challenges, but yeah, so then, long term, beyond that is the transition, because we cardiologists often don't even see them until like much later. So this is really why we need to empower primary care and use a multidisciplinary approach, because we may not even see these patients. But there's a lot been piloting with, use of like GLP-1 receptor agonists and SGLT inhibitors for like women with history of prior GDM for prevention. But yeah, no, I think that we need as a society, as public health, be thinking about ways that we can, novel ways we can deliver prevention. The clinic-based model is not sufficient enough. It's too hard to get people in to clinic. And that's why we really need engaged community partners. I mean, look what we've done with the barber shops and faith-based organizations. I mean, a lot of this basic prevention and blood pressure monitoring can be delivered by trained lay individuals who actually may resonate more with the population than I do as a female physician, where there's often a lot of mistrust of the medical system, rightfully so, because of a lot of the legacy, like Henry and Relax. And so this is why partnering with the community is so important, because they can actually, reach the vulnerable patients and resonate more with them.
Really great talking to Lynda.
Yeah.
And I felt obliged because she actually is the one who listened carefully to everyone. Her notes were meticulous, and I feel it was a place to learn about the patient. Long notes, and I listened to every aspect of the patient. Now I have two questions. You emphasize on PCOS and also preeclampsia. And preeclampsia, initial studies showing that there's association with prolactin levels, and also placental growth factor and EGF, which actually EGF is the locus for coronary artery disease in GBOS. So what have we done in terms of therapy and success in reducing kind of risk for events like, right, that maybe bromocriptine or whatnot? Also in PCOS, has any study been done to put a metformin to sensitize and see if that can reduce it? I know you have a lot of negative studies with metformin in many areas, but
well, PCOS, metformin is used and has been used. There's some ongoing studies now with GLP-1 receptor agonists, which is off-label, if they don't have diabetes. But I think that's particularly because that may have cardiovascular benefit and the weight loss, because although there is that lean PCO phenotype, majority of PCOS do have elevated adiposity. So I think GLP-1 receptor agonists might be really helpful in the PCS population. We're sort of using them anyway, but it's sort of off-label, and there's trials ongoing. In terms of the preeclampsia, so of course there's a lot of things trying to prevent it from first place. The exciting thing was a big trial at ACC about treating chronic hypertension, at least more aggressive targets with the CHAP trial. So treating blood pressure less than 140/90. Aspirin is not perfect, but we know we give aspirin in patients who have high risk for preeclampsia, has some benefit. And there's ongoing looking at statins, because statins can decrease, may improve endothelial function and decrease and other these factors. And so the trial that was published last year, they gave statins at like 32 weeks, which is way too late, like, you know, in the pathology. So there's an ongoing study now looking at preeclampsia for prevention where they would give it at 12 weeks with pravastatin. So right after the first trimester. So an early enough time that they may be able to help potentially prevent preeclampsia. So I think it'll be really interesting if statins are shown to prevent preeclampsia. Doesn't we turn the pendulum the whole way, like from completely avoiding statins and women are pregnant to actually using it as a therapy for preeclampsia prevention. So that's the ongoing work, is the statin trial, I think is the big one, and then treating blood pressure better and using aspirin are the mainstays.
Any last question? Sarah?
Thank you. Thank you. That was a wonderful lecture, and thank you, Dr. Rosenfeld, for being a trailblazer for women in cardiology. This is a little bit of a philosophical question, and I don't know that there's going to be one clear answer. It's more sort of food for thought and discussion. Because I struggle a bit with, on the one hand, the necessity to recognize like that there are biological sex differences. Women are not just small men, but at the same time, I have some concern that because of this underscoring all of the differences between women and men, that sometimes then just sort of exacerbates our gender perceptions of women and men, when in fact, even though women have often, you know, classically slightly different phenotypes, they present at different ages because they have protection, hormonal protection menopausally, at the end of the day, a lot of what we're doing to reduce their risk are the same things that we're doing for men, right? Like treat their hypertension. When they know anginal symptoms or anginal equivalent symptoms, take it seriously, test them, even if they have non-obstructive disease. You should still be treating them with a statin, right? Like if they have a coronary artery calcium score greater than 100, even if they're asymptomatic. So I struggle sometimes because I think, and again, a lot of this is just anecdotally driven by what I see in practice, which is women who I see who have traditional risk factors for coronary disease, and were just dismissed because they were too young to sort of.
There's lots of evidence, not just your anecdotal evidence, showing that women are undertreated. So for both primary prevention and secondary prevention, so women are less likely to be prescribed statins, they're less likely to be maintained on statins, and more likely just to continue statins. They are more likely to report statin intolerance, but we have lots of other agents now, new kids on the block, but yes, women are clearly undertreated. And there's also, I'm glad the new chest pain guidelines made this push to get rid of the word atypical. There's this misperception that women with ischemic heart disease have these atypical symptoms, but the word atypical, we really want to discern between non-cardiac chest pain and cardiac ischemic chest pain. Studies have suggested that in the setting of ischemic heart disease, acute MI, 90% of women have chest pain too, the same as men. So there's this myth out there that women don't get chest pain with ischemic presentations. That's not true. But the study suggests that women are more likely to have 2 or 3 other associated symptoms. So they have chest discomfort, but they have all this other stuff, nausea and shortness of breath and all these other symptoms. And so that can be distracting, where both the patient and the clinician start thinking about other, diagnoses and overlook. And so women are late to be diagnosed with ischemic heart disease. There's some thought that they're somehow protected by their female gender, but we know that there still can be early onset of CVD even before menopause, and women are undertreated. So we need to make sure we're applying the guidelines equally to men and women, in addition to be thinking about these other unique factors that women have. So you got to do both. Well, thank you so much for having me here. With the technical problems, I know we started a bit late. Yeah. So. Great.